Good morning, everyone. My name is Guillaume. I'm from Seattle. I work at the Institute for Disease Modeling. 5 years ago, I started working for IDM and worked on a variety of diseases. The one that I work most on has been polio, but my colleagues also work on HIV, malaria, tuberculosis. So it's only a small part of what the Institute does, and there's so many people working on polio that this is just the part about disease modeling and eradication. So it's always good to give a little bit of context, even though many of you may already be very familiar with polio. Separating the infections from the disease is perhaps most important in this case, because a very, very small fraction of all the infections actually cause disease. In most cases, if you are infected with polio, you might not even realize it. You might have no symptoms at all. And in less than 1 out of every 200 infections, approximately, you'll have a form of paralysis, which is poliomyelitis. As you can see on the right, there are two examples of what this paralysis can be. At the top, you have these iron lungs. One of the forms of paralysis is a paralysis of your breathing muscles. And in this case, to be kept alive, they needed a ventilator. In other places, there's no access to such technologies, so paralysis of the breathing muscles would cause death. And here you have some examples of polio-caused paralysis in the DRC. So the agent of the disease is the poliovirus. It's an enterovirus that is transmitted from hand to mouth. You can excrete it in your feces, or you can excrete it through your pharynx if you're infected. There are 3 serotypes that are named 1, 2, and 3. That distinction is important because you have really 3 different types of virus, and you need to have immunity to all 3 types to be protected against paralysis. I introduced this notion of case to infection ratio. That is the fraction of all infections that cause disease. The ones that causes the most disease is type 1, where you have 1 out of every 200, or 0.5% of cases. 0.5% of infections are cases. Whereas for type 2, it's more 1 out of every 2,000 infections. And for type 3, it's in between. There are 2 types of vaccines that exist. A vaccine based on killed viral particles that was licensed for the first time in 1955, the Salk vaccine. The difficulty with this vaccine is you get great serum immunity, but your mucosal immunity, your gut immunity, is not as good as as created by the live vaccine. The Sabin vaccine is an attenuated live vaccine. There you can get great immunity. It's easy to administer. It's administered through giving drops of a liquid in the mouth, so you can use it effectively in mass campaigns, which is more difficult for the killed vaccines. But in areas where you have a lot of antiviral pathology, your vaccine will be less effective. And this is perhaps most important when you get very close to the end. In rare cases, the vaccine actually can cause paralysis. If you 1 out of every 500,000 person that gets the vaccine can get paralyzed by the vaccine directly. And in certain cases, the vaccine can even start to circulate within a community and cause paralysis. So to give a very brief history of polio eradication, I thought I'd put together a simple graph for you that summarizes the total number of countries that report cases per the WHO database. That's the blue curve. The estimated number of cases globally is the green curve. You'll notice that I give an estimate of 500,000 infections in 1980, but at the time the number of reported cases was in the 40,000. So there's a lot of underreporting in the 80s, and at the time they were doing surveys to estimate incidence. Now, as of September, there's approximately 49 cases globally. all of this year, all of type 1, all of wild type 1. So I'm not, sorry, this actually includes the circulating vaccine derived as well. So to move through the timeline, in 1974, the expanded program for immunization was established. So they start to give the vaccine against polio in Africa, for example. In the 80s, the Americas is making a lot of progress controlling polio. And in 1985 starts their own polio elimination program from that region. And they're making a lot of progress, and it convinces the world that polio eradication can be done. So in 1988, the World Health Assembly makes a resolution to eradicate polio from the world, and to do so by the year 2000. So 12 years to get to the last case of wild polio and certification, which was a very ambitious goal and turned out to be, polio eradication turned out to be much more difficult than anticipated. As you can see, a lot of progress was made right before the deadline in 2000. A lot of countries stopped having cases reported. The number of cases worldwide decreased. But it was followed by a period in the 2000s where a lot of countries became reinfected. There were outbreaks outside of the kind of the foci countries, and that took quite a while to resolve. In fact, I added a line which is the number of endemic countries in red, which are these quote unquote most difficult countries: Nigeria, the India, the Pakistan. And now I'm being a little bit optimistic. I said in 2015 there were only 2 left. That's because Nigeria is on the verge of being taken out from the list of endemic countries. It's gone more than a year without wild poliovirus. You'll also notice that I indicated 2 dates, 1999 from the last of all the wild type 2 viruses, and 2012 for the last of all type 3 wild polioviruses. And that distinction is important. Is it you can have poliovirus that circulates and paralyzed, but can be derived from the vaccine, or can be wild in this case. So to give a brief idea of all the challenges and how difficult it is it has been to eradicate polio, I thought I'd use a slide from the CDC that shows the number of outbreaks that took place just between 2002 and 2005 outside of these endemic countries. You'll notice that at the time, Nigeria, Niger, Egypt, and Afghanistan, Pakistan, India were endemic countries that had never interrupted polio ever. That is, since the dawn of time they had polio. And all the countries in green were countries where transmission was reestablished, that had been interrupted, and then these outbreaks reestablished transmission in those countries, so they had to fight it again in those countries. And I've noted a number of years on the slide that indicate the number of these outbreaks that they had to not only fight the disease in these endemic countries, but also fight it outside. In addition to a number of issues of vaccine refusals, inaccessibility, unrest, difficult to reach communities that made this segment of the campaign very difficult to make progress in. And one of the big issues with a program that needs to fight a disease on many fronts is that it costs a lot of money. There was a major impact in the 2000 on the finances. In the year 2000, the global budget for polio was about $400 million. And in the following 10 years, that figure increased almost up to $1 billion. And that is roughly the burn rate as of now of polio eradication. And what's difficult is if you're trying to raise money every year, if you face a budget shortfall, you may have to cancel vaccination efforts, which increases your risk for further outbreaks, which may increase your need for further funding. So in 2012, there was a realization that there needed to be fundraising of the bulk amount that would allow the program to operate until the end and have no more of these funding shortfalls. So at the time, they were able to raise $4 billion out of an estimated $5.5 billion needed to finish. Now that this figure is increased up to $7 billion, which, if complete, would have a total cost of eradication of $17 billion. You'll notice that the estimated benefit is still much greater than the cost to eradicate. But that's always provided that you're able to reach that. So there's always a chance that the program fails and that money was not as productive as it could have been. You'll also notice that this graph is a little bit cynical because I'm showing not only the expenditures for each of these years, but also the projected expenditures that the program estimated for each of these years. In each of these years, they thought the following year was going to be the most expensive. And right after that, their cost was going to decrease. And year over year, they realized this had to be pushed back. So that decade was a decade of realization of the difficulty, I think, in my opinion, of eradication and of the growing costs. So I want to give a couple of examples of how science can help and be useful for eradication programs, starting with kind of the efforts that happen within a program to manage the risk at the continental scale, right? I've just shown you how transmissible the poliovirus is, how quickly it can leave an infected country and go to an uninfected country and create these large outbreaks. So this is a map of the estimated fraction of children 0 to 5 that have received 0 doses of polio vaccine. In a sense, it's a measure of susceptibility. The more red this map is, the more susceptible that region of the world is to outbreaks. Now, you'll notice, for example, the Horn of Africa is very susceptible, and over time, especially in the southern part of Somalia, there's been a lot of unrest and inaccessibility. It's been difficult to conduct vaccination there. So, in a sense, these regions it's not particularly surprising that this region is red. You'll also notice in Pakistan, along the border with Afghanistan, there's a tiny region of red, and that is the federally administered tribal areas where there are drone strikes, vaccination bans, a lot of unrest, and it's very difficult to access for vaccination. Now, of course, susceptibility is not risk. If you have virus in Nigeria, you have to try and understand how it travels to Somalia to understand how do I prioritize vaccination in Somalia versus Kenya versus Sudan, for example, or Senegal, or parts of the Pacific. And that's a bit of the difficulty that we face in doing this work is you may have a measure, perhaps imperfect, of susceptibility, and you have to combine it into an estimate of a programmatic action, which is a number of SIs. And this was actually done in collaboration with the partners. So we were a participating group, and we make maps of this type, and we estimate risk, but our colleagues at the CDC also do, our colleagues at the WHO also do, and we combine all these three, these models into a consensus risk score and use that to determine how many SIs are conducted. Now, this was the global, kind of a global view. I want to give an example of a single country to give kind of a little bit more detail about how complex the situation can be in a single country. This is the timeline of reported polio cases in Nigeria from 2004 until now. The red bars are wild type 1, blue bars wild type 3, green bars are vaccine-derived type 2, and then you'll notice there's some green squares, those are mixed infections. So you can tell that there were quite a few infections in the early 2000s, but somehow around 2010, there was a very sharp decrease in infections. And then that was a very narrow bottleneck in transmission that the virus was able to pass through and continue circulating for 5 more years. There was a realization in 2010 that it was going to be very important to detect polio cases very effectively, but also to anticipate them. You'll notice the number of efforts that were made to fight the virus, for example, by changing the type of vaccine that's used. MOPV1 stands for monovalent oral polio vaccine type 1. So it contains only the type 1, because when you put all 3 types of vaccines in the same dose, they they interact in conflict with each other, such that the recipient can be immunized against only one of those types. The type 2 vaccine is the strongest, so it overpowers type 1 and type 3. So making these monovalent type 1 and type 3 vaccines was such that you can make the vaccine more effective in these places. And eventually they realized they could make a bivalent 1+3 vaccine where the interaction between 1 and 3 was small, and use it going forward. And since then, the trivalent and bivalent have been the main vaccine used in the program. What led to what I would say a very successful last few years in Nigeria are a very significant staff surge from WHO and the UNICEF. But also the deploying of some more technology around the eradication. For example, the tracking of vaccination teams with GPS units, very detailed mapping of every village in these very remote areas to understand which village was not being reached, which village was being reached, so that you could literally vaccinate every child. And a certain amount of technology and coordination. These emergency operation centers brought the partners together in a single place with the government to do to conduct this program. Now, I want to talk a little bit about one of our collaboration with the Nigerian government, which was in the mapping of the risk of polio across the north. So the north part of Nigeria has been the one experiencing the largest burden. And as I mentioned, when you have, there's very few cases that are discovered because the case to infection ratio is low. So it's difficult to anticipate cases. If you're only following cases, you're really trailing the virus. So you want to get ahead of the virus. You want to understand where are the susceptible within your very broad population. So which is a kind of a very good problem to build a risk model on. So in order to do that, we wanted to look at what predictors we could use to predict where cases would be next. And what we found, what was most striking is the best predictor was the sum of cases historically in a certain district. So a district that had a case or a lot of cases 3 years ago could be more at risk than a district which had a case just last week. And to us that meant that the best predictor was really an indication of chronic weakness. If you've had a very large number of cases historically, that means that you may have chronic underperformance or chronic issues or chronic risk in that LGA, which is what they call districts in Nigeria. Our approach included many other predictors, for example, the zero-dose fraction that I mentioned before. And in the end, we combined it similarly to the regional models with models from the country themselves, which had a lot of in-country experience, understanding of these LGAs and what their local risk factors were, and a models created by the CDC. And altogether, we were able to achieve fairly good predictive power, better than what you would traditionally achieved with a risk model. But the issue was that our model was of limited responsiveness because it was not strongly related to indicators of that the program could change. So in order to essentially find underperformance, you needed a good measure of coverage data. And in a program like this for vaccination, you may have measures of administrative coverage where you have an idea of how many vaccine you use per area. You may have maybe some independent monitoring. The polio program had a way to essentially sample vaccination coverage that was meant to be easy and targeted towards these highest risk areas. But there was an issue. There came to light an issue, which was the places that had most cases somehow seemed to report very good vaccination coverage. So if you have a measure of coverage which is not reliable or misleading, that can prevent you from finding underperformers. So in 2000, they introduced this technique called lot quality assurance sampling, which is essentially a small coverage survey of 6 clusters of 10 children. Very strict sampling methodology. And compared it to what the results were from their previously used independent monitoring methodology. So what the graph on the right, although it's a little bit complex, shows is the relationship between this new method of sampling and the previous method of sampling. If the two methods agreed very closely, all the color in the graph should be along the diagonal, right? If they don't agree, you could expect a lot of scatter or a bias. In this case, you can see a very strong bias that the previous method consistently reports greater than 90% coverage, which is a programmatic target, fairly independently of what the true, I'm going to use LQS coverage as a better measure here, of what the actual measure of coverage is. So there's relatively little information in what was collected before compared to this new method. You can only see this by comparing the two and matching these samples. They had an intuition based on cases that there was something wrong with their current measure. But with this new measure, which has now been scaled up to the polio-infected countries, you have more reliability and you can act more on these coverage information. Now, I want to transition closer to the end game and talk about how do we know that we're done, right? And what is the utility of knowing when we're going to be done? So the graphs on the right show a calculated probability of elimination. That is not the probability of 0 cases, the probability of 0 infection as a function of time. So this is time on the x-axis. And for the 3 types of currently circulating viruses in Nigeria, the type 1 shows to be with a high probability of elimination right now. The type 2 is in a steep part of the probability of elimination, but it's not quite done. And type 3 is almost certainly gone. And the reason why it's difficult to estimate this is because there's so few cases per infections. And that's going to be a recurring issue as we get closer to 0 because of the difficulty of certifying polio. So I'll briefly talk about vaccine-derived polioviruses. I only have a couple slides left. When you get very close to the end, when you have no more wild viruses around, what's left is what's created by the vaccine. So you know that you'll eventually have to stop using the vaccine because it'll be the last source of paralysis that you have. As I mentioned, there can be vaccine-associated paralytic polio, or they call it VAP, in primary vaccine recipients that are healthy. If you're immunodeficient and you receive the vaccine, you have a much greater chance of being paralyzed. So they're immune-deficient VDPVs. And the last type, which is perhaps the most dangerous, is the circulating vaccine-derived polioviruses, which are the vaccine that reverts back its neurovirulence and its transmissibility. And this map shows kind of the number of emergences of circulating vaccine-derived polioviruses of type 2 only that have happened in the last 15 years. And you know there's been quite a few geographically broad. The biggest centers have been Nigeria and Congo, and some have lasted for 10 years. In Nigeria specifically, there's a cluster which hasn't been seen since last year, but is 10 years old. That is a type 2 vaccine-associated circulating virus that is circulating that country for 10 years. There's also, so the current CVDPVs now are in Mali, Pakistan, and Nigeria. There's even a CVDPV of type 1 in Ukraine right now. The unrest in that area is really taking a hard toll on the health services, and there's quite a few circulating in Madagascar. This is kind of a focus on Nigeria. You'll notice there's quite a few vaccine-derived polioviruses, and this is an example of how we might use mapping, modeling of immunity to inform the program as to how they can track and monitor their type 2 viruses. To save on time, I'll just jump to the last slide and try to give you guys an idea of where the program is going next. So this year was a very interesting year. They introduced the killed vaccine and routine immunization around the world, which is part of this transition away from the live vaccine. The killed vaccine doesn't create paralysis, though it's less effective at preventing transmission. And in April of next year, there will be a removal of the type 2 live vaccine from the vaccination that's used around the world. So all the CVPVs that I've shown you in Africa, the source term, right, in the sense, the reason we have those will be removed from the vaccination policy. Going forward, hopefully we'll see in 2016 the last case of wild type 1. And we'll have a global certification, hopefully, of wild poliovirus in 2019. We'll probably see some outbreaks of CVPVs in the beyond 2016, and eventually, as we remove all 3 live vaccine types, of other types of CVPVs. But if we can find a good strategy to interrupt any of these outbreaks, we have a chance to maintain the world in a completely polio-free status. There's a number of remaining research questions, which is a bit surprising considering how close we are to the end, but there's still research ongoing for polio. There's still very important questions left to be answered. For example, after we stop using OPV around the world, we'll probably still have to use it in outbreak response. And how much risk does that cause? How much OPV is too much? And how do we use the current vaccines that we have to interrupt circulation? What do we do with extended surveillance? When you don't have paralysis anymore, your surveillance system is not going to stay as strong as it is now. So you'll need ways to supplement it. And tracking poliovirus in sewers is probably going to be an important part of that. There's a lot of new data coming from trials around the killed vaccines and its ability to interrupt transmission that is currently being analyzed, and the conclusion of which will be interesting for Endgame. And finally, there's still some work being done on the transmissibility of the Sabin vaccine. So that's it for me. There's a lot of people that helped putting these slides together and did the work from the IDM team side, but also our collaborators in Nigeria and Pakistan at the Gates Foundation, and of course, GPI partners. Thank you very much.